A lot of what we've talked about is the need for community collaboration, for cross-sector, multi-sector participation and relationships. And we've also talked about this centralized system to identify and address social determinants of health and barriers to health. But we've also talked about this culture of positivity, openness, good rapport, and teamwork, and not competing with each other. And so there are three primary challenges we've identified. The first one is silos, and I know we all talk about that all the time, how we're working in silos in our own organizations sometimes even, but that we need to be working together. It's very fragmented right now, and we've talked about the need for a backbone organization to help drive this work. A second thing is poor communication. And so in a time of us doing things virtually, and I might read a text or an email from you and think, why was that so mean? Because you didn't put an emoji. I don't know. But it's very, very easy to misinterpret things, and our communication has not been strong or consistent. And so looking at pooling our resources, communicating together broadly, sharing the same messages with the same language repeatedly, consistently, has been another big theme.
And in that communication, no matter who's at the table, it comes back to sustainability. And many times that means, show me the money, right? So sustainability is one of those things that we have been dealing with in this space for quite some time as a program core. Many times you see large investments from our partners like the Duke Endowment and Blue Cross Blue Shield Foundation. But a lot of times the due diligence on us as directors, VPs, leading these community health programs is to go back and say, how do we braid and blend funding? How can we make up for that? We need more funding for staffing. We need more funding for, sustainability for training and professional development. And that has been the larger part of our communication, about the communication we've had as a core, is around the sustainability of our programming. Because many times, the programs that we lead are what I have termed our kind of incubation, right? Our learning labs about what we can do when we apply address social determinants of health or social drivers of health and what impact that has on outcomes. And so many times that is where it stops sometimes. And so that is a challenge. And I think out of all three, I think that one stands up true to the test of time for me.
We do the report.
And
then it goes on the shelf. We're like, that's a great
what?
plan. Here you go, we did it.
Yeah, and so some of that courage also is to get in front of those individuals who have the influence within our systems and have those conversations and ramping up communication and no longer working in the silo and truly being collaborative. And that means it starts with everyone. Everyone has a shared responsibility in this work. So then there's accelerator projects, right, that will need to be implemented. So we've been on the journey. Some of us have been to the design team meeting, and then we've done the learning collaborative, and now we're doing the core, and now within any, rhythm that we go into, it's time for the implementation. And many times that's through accelerator projects. But I will share this with you, leading an accelerator project around diabetes prevention really helps shape in funders or people that have resources about what can be done. And so then that's another opportunity to collaborate. So these accelerator projects that are coming up are going to be so influential in the next phase of this work. And then
Shanisha's gonna show
some slides around the challenges, visioning, and assets here. So the programmatic core, our purpose to drive the improvement for priority populations through cross-sector collaborations. Those were some of the key activities and workshops that we had. But when we went through this exercise, man, Carrie, any feedback you have from that session where we just kind of went over what some of those challenges were going through these slides and that long list that we have?
The conversation was great. The trying to use technology to put sticky notes on something was the hard part for me. But yeah, those three things really stood out, the sustainability, the communication, and the silos. So that's where we're focusing our efforts.
Yeah.
And to get all this done, you called them the most important group, but we have to because those data people have, a complex. So we want to introduce our data. Well, we have just one of our co-chairs here today. So Melissa Fair will come up and share more about the next from theirs.
Y'all are a tough act to follow. So I'm Melissa Fair, and I'm with Furman University's Institute for the Advancement of Community Health. And my data co-chair, Summer T-Ball, could not be here because of a long-standing prior commitment. So I wanted to recognize her because she's been integral to this work as well. So our vision in the data core is that we would have robust data sharing agreements between all of our partner organizations with high levels of trust and where everyone understands the importance and value of this data. To do that, we see a vision for a case referral management platform that has a centralized repository where data are available at different levels of analysis and units, and that data is secure and accessible to the public or anyone who wants to use it to inform their organizational practice. Going through this work, we did identify that there are some significant concerns, and we were open about that. One of the biggest is security concerns. Data risks in data sharing, cybersecurity. Some of our data also has limits on how we can share it and in what form because of things like HIPAA and FERPA. So we recognize that things have to be in place to protect people's information and or structure the data in a way that it's de-identified. To date, there's no central repository that exists for us to use, so there has to be something created, or something from a partner would have to be built to meet the need. We also identified something we called vision-impaired collaborations. As organizations, we all have different missions and goals and do different types of work, and sometimes these can create differing timelines, competing demands. We're using different systems and platforms that make interoperability difficult. And sometimes there's a lack of transparency about what data is being collected now and or how it can be available. So out of these discussions, we identified a vision and a need for a single case referral management system and platform. This is backed by results from a 2019 nationwide study that talked to more than 300 organizations, including healthcare systems, including federally qualified healthcare systems, rural healthcare centers, and safety net systems like our free clinics, as well as community-based organizations. There were a couple of key themes that came out of this study. The first was that we need a resource directory that's updated frequently and has real local data in it, not just a list of organizations with contact information. We also need a referral. It needs to have outgoing referral capability with a closed loop referral feedback where the information is exchanged between the healthcare provider and the community-based organization. Another key finding from this study was that we have to co-create this. We can't just create it in the silo on the healthcare side and then ask our community-based organizations to uptake and use it. This also means that training isn't just enough. We need to help them create infrastructure and make sure that they have the resources to hire, train, and maintain staff that can use and implement the system. The benefits of this would be, of this single case management system would be reduction and duplication of efforts. We would have reduced gaps in the continuity of care for individuals in the community, and we would have the ability to pull all of our resources to maintain a single system rather than each organization trying to support their own. We recognize that there's challenges though. There's federal rules that are evolving that mean that if we ultimately select a system, we don't know if that system will meet the needs of those guidelines or if it can be changed or upgraded to fit those regulations. We also need organizational buy-in from all of the partners across the state. Another concern is CBO's capacities, especially smaller organizations with really lean staff. This is one more thing for them to do that they could ultimately feel like takes away from their ability to serve their constituents or clients. And the last is that it needs to meet the needs, this platform needs to meet the needs of not just the healthcare providers, but the CBOs as well. And is that all? Okay. So next we have our admin core, and I think Naomi is going to be representing them.
Okay. I'm here as the co-chair of the admin core. We're really excited to be doing this work and just wanted to talk you all through what our conversations have been. So what we really see is a more formalized and robust relationship between the community-based organizations and our healthcare systems, right? Because we're often working with the same people, but in different ways. And so we want to certainly see a more meaningful relationship built there and a more formal partnership. Sustainable funding sources, you'll hear that from everyone, right? That means oftentimes I think we take up work and then the hardest part is the sustainable funding. We say it doesn't work. And the work does, but the funding doesn't. And so what type of work do we need to do to assure that investments follow the things that work? Cross-sector communication and data sharing. You heard that from the data core. We agree from the admin core. Obviously, you'll see some continuity in our messages around the need for case referral management systems, because that really is about the individuals involved and how they move from place to place and how challenging that can be. And a dashboard that shows positive health outcomes, right? The ability to see what's going on in the community level and be able to communicate that. Based on a diversified set of data. And trust building is important, right? That we trust each other, that the systems themselves, that we're all working together. And that racial equity needs to be a part of that, right? We understand if we move to a system, are we, whatever system we're using, is it inclusive of everyone in every community, and that needs to be at the forefront of the work that we're doing. So, it's find what works and do more of that, right? Like, that's always a model that we try to use. So we looked at other states and how they funded their social determinants of health efforts and examined sustainability strategies. So you can see here, how do we use Medicaid dollars for food insecurity and housing? We know those are two major areas that impact health outcomes. And then testing the value-based payment models. And learning through the Healthcare Payment Learning and Action Network Alternative Payment Model Framework. That's a lot. So with 3 phases, so you'll see here on the screen that all 3 of the phases and how you work through. So hopefully everybody has their reading glasses on and can see that far. But there's the short-term, low-risk fund for pilot and demonstration projects and small-scale federal grants. So, we're looking at what has worked in other places to assure sustainability. So as all of you put your time, energy, efforts, collaboration into this, we want to make sure that we leave a long-term legacy, not a short-term project. And in order to do that, we move on to phase 2 and phase 3, which is program expansion after demonstrating promising results, right? Asking ourselves important questions as we go, like, is it working? And then dedicated state pools or trust funds and Medicaid waivers. And that takes all of us and all of our voices added to the conversation to make that happen. And then phase 3 is the dream, right? Is the fully operational programs that are demonstrating positive outcomes and cost savings supported by combined sources. So, and then looking at blended and braided local, state, and federal financing. So those are the key strategies for what we are looking for and why we hope you all continue to show up to the table. That this is a marathon, not a sprint, and that it will take longer-term dedication, but there is a path, and we'll continue to learn from that. And so that is, from the admin corps' perspective, what we see as the key components of really bringing it all together. So I think that's it from the admin corps. And I am going to pass over to my lovely counterpart, Greg Parabell.
Everybody, I'm Greg Maribel, pediatrician, and I pivoted from being chief medical officer of one of the Medicaid managed care organizations in South Carolina to work, more directly with community and community organizations. Very proud to say I'm the physician advisor for the South Carolina Office of Rural Health, and I get to work with Pam Gill and her team, Julie Smith and her team, and really to bridge the gap between what's happening in the community, what the payers do and know, and how they work with Medicaid. So for this project, we asked that that we could engage with the MCOs and he said yes! So we have five managed organizations in South Carolina. The two with the stars are organizations that also have sister plans in North Carolina, so we're very interested to talk with them about their experience. So Absolute Total Care, First Choice by Select Health, Healthy Blue, Humana Healthy Horizons, which just came into the state July of 2021, and Molina Healthcare. Anyway, I got really silly with transitions also. I was having a lot of fun. So we did an initial survey to kind of guide what is going to be our qualitative interviews with the managed care organizations to talk about the different components of what they think they need to be able to participate in a meaningful collaborative. They didn't put it on there, but obviously it's money. I mean that's. But the and I think from what we heard from the survey is a lot like what's coming from the courts. Everyone is aligned in the same way to want to move the needle forward, or move everything forward in social terms of health. But it's what are the drivers that can happen? So right now what they're doing. So they are in some ways collecting information about social determinants of health. They're using multi-channel sourcing, meaning they're doing the web, smartphone, the please press 3. Our options have changed. But across the board, I think because it's DHHS sponsored, they're all integrating the findhelp.org, used to be Aunt Bertha, as ways to connect to the community resources. They're using standard screeners like the Prepare, but also all of them have their own proprietary customized screeners, and a lot of those are built into their case management, sometimes their utilization management platforms. They're using claims-based, so ICD-10 codes, the Z codes that indicate that there is a social term of health issue. The two problems that I see with the Z codes are, one, is that for pediatrics, it leaves out that a child can be affected by a social determinant of a parent. And so we haven't gotten to the place where you can say, because of a caregiver's social determinant issue. The other thing is with the Z codes is that while I could say there's a presence, there's nothing to say that there's the absence of it, right? That's been addressed, and so it's not really a great way to be able to track longitudinally social determinants of health and the correction of it. And they all have proprietary population health software that's now integrated with social determinants of health with their medical and pharmacy data. And these platforms, I call them artificial intelligence. Because they have these predictive models of here's how much this person's going to cost next year. Here's the probability they're going to go to the ED or the hospital. But what I see in that is a way to peg the cost savings that happen in a system to interventions that are going on. But in doing that, you really have to think about, interventions are multi-layered. And so even if, we're addressing something in terms of food insecurity for a diabetic, I think of like a 100-point scale where there's still, the physician, there's the diabetes educator. So we have to kind of think holistically also about where we attribute cost savings and improvements in health. So the social determinants initiatives, and it just kind of came to me as I was sitting here looking over my slides, that if you go to SouthCarolinaHealthyConnections.com and just find a health plan, and you look at the different managed care organizations on the bottom, it has their value adds. And these are things that are paying outside of the Medicaid dollars, but they really are, if you look through, a lot of them are going towards like GED programs, bike programs. A lot of stuff around nutrition, some post-COVID, some for pregnancy, and affordable housing. And so, they're already doing these things. And so I think there is a way to take what we're doing right now and be able to start integrating in to get some cohesiveness around where they're putting the money, how they're investing it, and because a lot of these are local, to kind of bring them more statewide. And we asked them, so you said they're working with you guys, right? Like in some sense, they are working with organizations, but there's not cohesiveness around, who they're working with. And so I think it'll be interesting to kind of come back out to you guys as our community partners and say, which managed care organizations are you directly working with? And then to be able to, kind of socialize the information for the ones that you are. So, and kind of the core of it, I think what was year one of the North Carolina 1115 waiver was the infrastructure needs. What needs to change? What do they need supporting from an administrative perspective? Again, what are they expecting the state Medicaid authority to provide for them to be able to do these components? So, and again, a lot of them are very, very similar to what's coming out of our codes. So the standardized information exchange, both a health information exchange and a community information exchange. And I think, in my mind, those, they have to be thought of separately. Not that they're not integrated, but they serve different functions, different purposes, and also they have different security risks, right? And so, kind of separating out what they're doing, but then bringing it back together for what they can accomplish, I think is something that's important. Data to support health equity certification. So there's the National Committee on Quality Assurance that now has something called a health equity certification. And it brings in multicultural healthcare distinction components and then social determinants of health. And a lot of these, in the beginning, it's data sharing, it's making sure they have the systems, aligned to be able to collect that information. But this is something that I think is a value driver for them because they have to do it. And so we're looking into how do we integrate in what we're doing. So the transportation systems, central data sharing, the mechanisms to support community-based organizations, which again I think something that North Carolina did beautifully, and that we need to look at here, and then the consistent funding. That's it. Thank you.